Good afternoon, folks. Tim Radford here on WKRK in Murphy, North Carolina, 105.5 FM, 1320 AM, cable TV channel 25. Worldwide, we're at WKRK.love, and this special interview here on Facebook Live. Hope you're having a great day today, and we have a great interview today with Dr. Jahania of Erlanger. So good afternoon, Dr. Jahania. How are you?
Good afternoon. I'm doing well. Thanks.
All right. Well, today we're going to be talking about the subject of low-dose CT program. But before we get to all that, so let's just learn a little bit about Dr. Jahania. Can you tell us about some of your experiences and your passions that drew you to? Now, can you tell us the field? It's the cardiothoracic. Is that correct?
Thoracic.
Thoracic. Yeah. So tell us what that word means in everyday language.
So it's Latin, like most things in medicine. Cardio refers to the heart and attached blood vessels, and thorax is the word for the chest. So anything that's got to do with medical care of organs between the base of the neck to the start of the abdomen, whatever organs are inside, so such as the heart, the major blood vessels, the food pipe or esophagus, the lungs, the diaphragm, the ribs, etc. So a cardiothoracic surgeon addresses those problems. And some people further subspecialize in a certain section. So some people choose just to do heart surgery. Some people choose just to do non-heart related chest surgery, etc.
All right. Since I've been doing these interviews with Erlanger practitioners, I've learned a lot of medical vocabulary over the past several months. So I'm thankful for that. And it's great information to pass on to our viewers as well.
Mm-hmm.
All right. So tell us what drew you to this field, and what is your passion in your field?
Yes. So the earliest I can recall thinking about possibly having this career, and I'll date myself, but it was back in the mid-'70s where I saw a documentary on a surgeon that was located in England as a heart surgeon, and he was going to fly from England to the Netherlands or Holland to bring out a heart from a person that had brain dead, and that organ was donated, and the recipient was in England, London. So he was flying on a jet from England to Netherlands to procure that organ and bring it back and then implant it to the recipient. And to me, that was just mind-boggling, being in school and not understanding how that would work. And I said, well, one day maybe I can do that. So that was the start of a long journey. Of course, you had to finish high school and then college, and then manage to find yourself in a medical school, and then to do well enough to be able to come to the United States and pass the medical boards and be able to get into a general surgery residency and then a fellowship in cardiothoracic surgery. So my training alone after medical school was 9 years.
Wow. So it took a long time to get where you are now.
That's right.
And we're just excited knowing that you're here in our area and you're able to see patients here from Western North Carolina. We also serve Northern Georgia and Eastern Tennessee. So how long have you been here at Erlanger?
I came to Erlanger in April of 2017, so it's coming up on 4 years. And because of my training and previous jobs, I happen to have lived in many states, including Colorado, New York, Wisconsin, Kentucky, Michigan, most recently, and then Tennessee. And I have to say, this is by far the best place I've enjoyed living.
All right, fantastic. Well, let's talk about lung cancer. Is that something that's pretty common here in our neck of the woods?
Yes, so good question. Traditionally, the tobacco states such as Kentucky, West Virginia, North Carolina, and Tennessee were considered the Tobacco Valley, and that's a direct correlation with the incidence of lung cancer. For instance, both North Carolina and Tennessee are in the top 3 and 4 spots in the country for incidence of lung cancer-related disease and death.
It's interesting because I do remember when I was growing up learning everything I learned in school. I did learn that tobacco was our biggest cash crop back then.
That's right. And that's the hard part of it, is that when you have an entire economy based on a certain crop, you can't just stop it overnight. You have to invest money into the community to help people have alternative careers, and their generations have lived off of that, and it's hard to change overnight. So that's been a challenge.
All right. So, what kind of patient lifestyles or risks that they may be taking with their lifestyle? What kind of habits are we going to be looking for? We're talking about the low dose CT scan program.
Right. So just to clarify to your audience, the low dose CT scan program is a program designed to detect the presence of lung cancer in its earliest stages. So based on a clinical trial that was done probably about 15 years ago now, and that was published in 2011 in the New England Journal of Medicine, that really established for the first time that there is a study that can help pick up lung cancer earlier, and as a result, save lives by detecting cancer in a stage where it can be treated and cured. So that led to the recommendation that a CT scan, which is a computerized tomogram, it's a fancy word of a special machine that uses X-rays in a circumferential manner and develops a three-dimensional picture of the patient's body that then can be interpreted and looked at to see if there is a small spot or a nodule or a mass in the lungs. The low dose part refers to that this scan is designed to give the least amount of radiation in order to be able to effectively still pick up small masses of nodules. So the regular scan is designed to detect everything. So as a result, that requires higher dose of radiation. And the program involves that the patients that are specifically at high risk, to answer your question, these are patients who have smoked for at least 30 pack years. A pack year means that someone smokes a pack of cigarettes a day for a year. So that's one pack year. If they smoke a pack a day for 30 years, they're considered a 30 pack year history of smoking. And especially if they're between the ages of 55 to 80. And they're either currently smoking or they have quit less than 15 years ago with a 30 pack year history. Now, a 30 pack year also could be someone who smokes 2 packs a day for 15 years. So if they have quit more than 15 years ago, then we do not usually recommend a low dose screening CT.
All right. So suppose that I'm a candidate for this screening. Tell me what my experience is going to be like once I come to your office.
So usually the primary care physicians will look at your profile and say, yes, you meet the criteria, you're within the right age group, you're otherwise healthy, you don't have current symptoms of cancer, and you're smoking, and you could undergo treatment if cancer was found. Then they'll do what is called a shared decision making, which is they go over what is a low dose cancer screening program, why do we do it, what are the benefits, who meets the criteria, and what would happen should something be found, and what would happen if nothing is found. So then patient agrees, and they are counseled regarding tobacco cessation, and all of that is documented in the medical record. At that point, the order is placed. And then for patients that we come into the Murphy area, they would get their scan at the Erlanger Western North Carolina Hospital. And then the report is generated, and it describes the score or the likelihood of anything found in the lungs to be lung cancer. So the report will say either 1, 2, 3, or 4. There are subcategories of 4, but we don't need to go into that detail. That report is then sent to our coordinator, who then collects all the reports for the week, and then we review them once again at our special weekly meeting. And at that point, based on all the criteria, we will send a letter back to the patient and the patient's doctor that such and such was found, and we recommend one of 3 things. If there's nothing found, then you will have a scan in 1 year. If a spot is found, but it looks low likelihood of cancer, then we usually say either 6 months or 1 year follow-up, depending on how small the size is and where it's located. If they're more suspicious, then they get a 3-month scan. If they're further more suspicious, then we usually send them to a specialist, and they will do a PET scan, a biopsy, and that could involve later down, if it's stage 1 or 2 lung cancer, surgery to remove that cancer.
All right. Are there things that can lead to lung cancer that is not related to smoking?
Yes, very good question. And specifically as related to Murphy, radon gas, which Murphy has a high rate of radon in the soil. So that activity, that's not something that you participate in, but should be aware of. And the state of North Carolina actually sponsors free radon testing kits that can be placed. And if there is a certain threshold and above, then you need to see a physician, do radon abatement at the house, and also talk about doing a CT scan to look for that.
All right. Suppose that I'm not a smoker, but I do have the radon there. Are there symptoms that would tell me that, hey, I need to be screened?
Unfortunately, lung cancer in the early stages causes no symptoms.
Wow.
And that's why screening is necessary. And for example, early prostate cancer also doesn't cause symptoms. Small breast cancer won't be detectable many times. Colon cancers also don't cause early symptoms. So that's why there's screening programs for all of them. But cancer screening for lung cancer is 4 times more cost effective than any of those other screenings. It would take you 800 mammograms and 1,200 colonoscopies to save 1 death from either breast or colon cancer, but it takes only 320 low-dose screening CT scans to save 1 lung cancer death.
All right. So I know that vaping is popular nowadays. And has there been enough study, enough research done to see if that is going to cause any damage to the lungs?
No, because it's just not been around for that long. But it's definitely harmful, and we recommend our patients not to do that. There is some thought in the community that vaping is not as hard as bad. Is probably not just as bad, but also still harmful.
It is introducing things into the lungs that aren't natural.
A lot of the younger population that does do vaping, they tend to have sudden infections in their lungs and also fungal infections. So there are consequences that are not necessarily cancer related, but nonetheless harmful.
All right. Is there anyone who should not initially get or need a screening? Is there a population of folks that should avoid this?
Well, so as I'm mentioning the criteria, if you recall, the patient has to be healthy enough so that if the cancer is found, that they can at least have some treatment. So if you have someone who has advanced emphysema or obstructive pulmonary disease or severe heart disease, or they're debilitated by other things that they can't even go through a biopsy procedure or surgery or chemotherapy or radiation, then there's really no point in screening them. Patients who are already symptomatic from possible symptoms of lung cancer, then they don't need a screening CT, they need a proper diagnostic CT scan. So those are quick ones.
All right. You mentioned the symptoms. Let's look at those things that folks need to be on the lookout for. What are some of the symptoms they should watch for?
Yeah. So a sudden onset of persistent cough, that's usually a sign. Because smokers often have what's called a chronic smoker's cough, chronic bronchitis. But if they're suddenly starting with new cough that's persistent, especially if there's blood mixed in the sputum, if there's chest pain, if there's new onset headaches, because cancer of the lung does travel to the brain, it could cause headaches, it could cause stroke, it could cause seizures. it does travel to the glands above the kidneys. It goes to the liver very commonly, and it can also go to the peripheral bones. A lot of times we'll see people with new fractures that happen in the absence of trauma, and that's actually cancer spread to the bone, which causes it to weaken and break.
All right. And I believe on here is the weight loss without trying. I'm sure that's a big.
Yeah, anytime there's unintentional weight loss, that's a big sign for that there might be some hidden cancers.
All right. And lung cancer is pretty, for the most part, pretty easy to prevent. And it's basically don't smoke.
Right. So about 85 to 90% of lung cancer, at least in the United States, is associated with current or former smoking for a number of years. Some lung cancers do happen due to exposure to chemicals and genetic mutations that make it more likely. And those patients often are non-smokers. So, but the greatest burden is related to tobacco use.
And I know several folks, family and friends, all that have been smoking for decades, and
That's
it's not easy to give up for some folks. Are
right.
there some ways that folks can make this less challenging as far as stopping that habit?
Yes. So once the patients are found to have something like this, they're sent to a specialist, such as what we call pulmonologists, who do the initial workup. And part of that is counseling about tobacco cessation. What are the harms? And then there are a lot of chemical uh, therapies that can be given. Those include a nicotine patch that you can wear once a day on the arm that helps to get that edge off of the withdrawal from nicotine. And then there are also medications that can be given orally that help with managing that withdrawal of the nicotine. And
All right.
and there's a course that they can enroll in. We have special classes where people who are trying to quit come and have a community support and help each other exchange experiences, how they did it. It's usually a gradual decrease. So if someone's smoking a pack a day, that's 20 cigarettes. We usually tell them, for the next week, just do 15 a day. The week after, go down to 10. Week after, go down to 5, etc. So suddenly stopping, a lot of people can do it. It's oftentimes the realization that they've got cancer is enough motivation to just have them take their pack of cigarettes and throw it in the garbage. Some people can do it. A lot of people can't.
All right. I've never been a smoker myself. I know when I was in my teenage years, I was offered cigarettes. I probably tried one or two, but I, I've never seen the appeal personally of why to smoke. So, what are some of the weaknesses that people are facing? Why do they start smoking to begin with, and how can we prevent that?
Well, the start of smoking is purely cultural and peer pressure. Uh, there is no inherent deficiency in the human body that requires tobacco to be started. So it's a cultural thing, and uh, once you start and you persist, they say the magical number is about a month. That anything you repeatedly do for about a month becomes a habit, and at that point, you may not be chemically dependent. So all the chemicals in the cigarette create a certain state of the body with the stimulus that you then crave that. So it's habits, it's a addiction, it's a dependency. So that you need that on a regular basis to feel that way. And so it's hard, just like any other addiction. It's not as severe as narcotics or opioids or
So,
alcohol.
so the chemicals pretty much control you at that point, and it makes it hard to break from. Okay, that makes
Right.
sense then. All right. Well, one thing I do want to emphasize on is that here we are in Murphy, North Carolina. You're not that far away from us. If we go visit you in your Cleveland, Tennessee clinic, you also have offices in Chattanooga, Tennessee, which is still not that far away. So tell us about, I'm sure in Cleveland, you probably see some patients from Western North Carolina.
That's right. The location of this clinic, specifically for my specialty, was started back in October or November of last year. But because of the pandemic and a lot of shifting in the resources, restricting travel, we really only started seeing patients from Murphy at this location about a month and a half ago. And we've regularly seen patients now from Cleveland area and also from Murphy. And I think that additional 45 minutes adds about an hour and a half to the commute. And a lot of the people have kind of difficulty with resources getting through the mountains. So this definitely helps.
Well, fantastic. Well, I know during COVID-19, when a lot of people, especially when they first went into quarantine, alcohol consumption went up significantly.
That's right. Yes.
Do you have studies found that smoking has also gone up just to relieve some boredom?
I think across the board, all chemical use has gone up. It's been said over and over again. But of course, a lot of this doesn't hit the news or media.
Right. All right. So if someone wants to schedule an appointment at your office, do they need to go to their doctor locally first and then get referred to you, or can they contact your office directly?
They can contact me directly. But I think in Murphy area, we have Erlanger employed primary care. I happened to meet several of them a few months ago. They're very, very nice folks, very dedicated to the community, and they all have my cell phone. So whenever they see a patient, they just give me a call, and I'll be usually able to see them in the next day or two. But they don't have to necessarily go through them. A lot of the insurances require that a referral be placed, but that's not a requirement on our end, as long as we have the information available, so we can interpret it for the patient.
All right. Well, is there anything that you wanted to mention that I haven't asked in this interview?
Now, I think you've conducted a very thorough summary of the information that we needed to get out. But I would emphasize that a lot of people are unaware of such a thing. People who meet criteria should start the screening at age 55. And we often see people that are having their first scans in their late 60s and early 70s, where they've lost 15 years of opportunity to have found cancer early. So a lot of the physicians that have been in practice for over 30 years are still unaware of this program. So that's why we do a lot of community outreach. I usually try to come out every 6 months to a year to Murphy and meet the doctors. And in the past, we've had the women's one meeting that last year, I can't remember, ladies town hall or ladies night out.
Yes, that's it. It's on the tip of my tongue.
Yeah, I've been to that. So I try to take an opportunity to meet both the general public and the physicians to raise awareness regarding this.
All right. Well, fantastic. We appreciate what you do. And let me give you the phone number for Dr. Jahania. It is area code 423-778-5661. Again, area code 423-778-5661. Thank you so much for joining us today and providing this information to our community. We appreciate you.
My pleasure. Thank you for the opportunity.
Thank you. Have a great day.
You too.